Next topic, research. Trying to figure this out. Whenever I'm talking about 4P disorders and Wolf-Hirschhorn, of course, we're always, there's all these questions. I always say, well, we don't know that. We don't know that, right? There's so many things we don't know. So how do we get at that? So I'm a geneticist, but I'm a clinical geneticist. So my main focus is patient care. And a lot of geneticists are really interested in research, kind of for the sake of, because they love science. They want to do science. But for me, this is about answering all those questions of why and what do we do? And so, and the only way to get at that is to do some research. So I'm going to talk about, this is just a little update of sort of what I know about where the state of research is for 4P disorders right now. There's probably stuff I'm missing because I don't know everybody and I don't talk to everybody. And I'm sure when people haven't published yet, sometimes it's kind of under the radar. So sometimes we keep it close to the vest when it's not published. So there could be other cool stuff going on that I don't know about. So this is not all inclusive. But that being said, moving on. Okay, so one of the issues that just kept coming up when I was talking to parents, especially in our support group in the US, was the question of whether cancer is part of Wolf-Hirschhorn syndrome, whether there's a cancer risk. And if you look in the literature, it kind of doesn't really come up to any, if you look at a review article or an article that's sort of trying to just give you background and outline and what happens in Wolf-Hirschhorn, it doesn't really come up. But the parents of the slightly older kids kept saying, I feel like there's too much cancer. So Amanda and I and Dr. Carey really tried to look into this a little bit. This is a really tough topic to get at, but there is a little bit in the literature. So this is a summary of the cases that are reported in literature. And as you can see, I dug through again just recently here when I was updating this talk. And I always like to do this CSS last literature review because just to show you where we were at in case something came up recently, in case I missed one. That's when I checked. Okay, so there are 3 hematologic malignancies, meaning there were 3 patients who were reported to have some sort of what we'd call in the States maybe like a blood cancer. So 2 cases of cutaneous T-cell lymphoma, and of course that means it's in the skin, but it's a blood type cancer, so T-cell cancer. And then 2 cases of myelodysplasia. And so myelodysplasia isn't itself cancer, it's sort of a precancerous condition. It's an abnormality of the bone marrow function. So myelodysplasia, they get kind of scarring in the bone marrow and not enough production of blood cells. The bone marrow's job is to make blood cells. And patients with myelodysplasia, whether or not they have abnormal chromosomes, can progress to leukemia, and 1 did. And then 2 patients with liver adenomas, which are benign lesions in the liver, but one of the problems with adenomas is adenomas over time can progress to liver cancer, which is called carcinoma. 1 patient with an inflammatory myofibroblastic tumor. Now, the important thing to know about an inflammatory myofibroblastic tumor is it's not cancer. This is actually really a reaction to an infection. So that's really not considered a cancer, but I included it because it's a tumor. And if you look up, if you go picking through, if you Google, if you pick through the literature, this case will come up. And then lots of patients who have multiple hemangiomas. A hemangioma is a benign tumor. So actually everyone's probably seen a hemangioma. It's, people call it a birthmark. So you get bright red, slightly lumpy birthmark on a baby. They're really normal. So technically a hemangioma is in fact a tumor of blood vessels, small blood vessels, but it certainly isn't a cancer. It doesn't progress to cancer, but technically it's a neoplastic process, so it's a tumor, but it's not cancer. But technically, if we're looking at neoplasia big picture, we would include them. But this is a pretty common, but multiple hemangiomas is really kind of almost a normal problem. I mean, lots of kids have birthmarks, and so that's not something I'm really concerned about, but we have to include it for just to be complete. Okay, we have had several cases in our support group in the States So our membership of our support group in the States is probably around, if the kids, the kids who have 4P deletions is probably around 200, 300 kids and adults. I say kids, but actually a lot of them are adults. Loosely kids. So this is what we've seen. We've had one case of T-cell large granular lymphocytic leukemia. So this is a slightly unusual type of leukemia. ALL, acute lymphoblastic leukemia, the most common type of leukemia. ALL, when you know somebody who has leukemia, odds are they have ALL. One Hodgkin lymphoma, one case of hepatocellular carcinoma, which is a liver tumor, which I was talking about, the adenomas in the liver, the benign liver tumors. This is what they progress to, is hepatocellular carcinoma. Then hepatoblastoma, which is a different type of a liver tumor, and hepatoblastoma is a childhood liver tumor. So adults who get liver cancer tend to get this is an oversimplification. So I'm simplifying a little bit, but adults tend to get, when they get liver cancer, if you know an adult who's had liver cancer, hepatocellular carcinoma is most likely. Hepatoblastoma is when kids get liver cancer. That's the one they get. So 3 hepatoblastomas. And then we had some problems with, we think there was something, but we're not sure what it was. So there's one person reported a liver cancer that we couldn't get more details on. Another person reported a brain tumor that we couldn't get more details on. And then one person had a myelodysplasia syndrome. And of course, the question is, this isn't, considering our population, this isn't a huge number of cases. So I met with a specialist cancer doctor in the States who does primarily childhood cancers, specifically cancers where there's a genetic predisposition to cancer. And I kind of asked him, well, how does this match up, do you think, with, how many cases would you expect? Do you think these are matching up? And he said, well, this doesn't freak him out, but this is concerning. So that's kind of, because there's enough here that he's wondering if something's going on, but not so many that he's like, okay, everybody needs to have cancer screening every 5 seconds. So that was kind of his take on that. So then, of course, the next question was, does it make sense that there might be any kind of a predisposition to cancer in patients with Wolf-Hirschhorn? And so if you look at the cancer literature, which I wouldn't recommend it because it's mind-boggling and extensive. And if you're looking at, so cancer, which is what we mean when we say cancer, is an abnormal proliferation of cells. So too many cells that are just growing and growing and growing. And really they lose their function, what they're supposed to be doing, and just focus on growing. And what makes it cancer is that a piece can break off and go somewhere else, which we call, so it can spread over the body. And that's what makes you cancer. If there's no propensity to spread around the body, then it's a benign tumor. And we find abnormal chromosomes almost invariably. If you take a tumor, a cancerous tumor, and you look at the chromosomes in all of these different ways that I was showing you in the previous talk, you'll find chromosome abnormalities. All cancers have usually lots of different chromosome abnormalities, and each cancer cell may have a little bit different of a chromosome component. And so there's lots of papers out there where they've just looked at the chromosomes in tumors and sort of reported out what the abnormalities are. So problems with 4P are very common in cancers and cancer cell lines. So cancer cell lines are when they've taken a cancer into a lab and they're growing in the lab, which are not the same as tumors in the body necessarily. So this is another piece that made us a little concerned, is that you do see, when you look at the cancer, the tumor literature, you do see 4P problems. And specifically bladder cancer, breast cancer, colorectal cancer. So, and there are lots of genes that have been reported as oncogenes, i.e. genes that cause cancer, in that region. However, what makes you an oncogene is that you're a gene that if you're going faster and stronger, you cause cancer. So if it's more active than in a normal person, it causes cancer. Of course, in Wolf-Hirschhorn, we're actually missing copies of these genes. So here's LETM1, which is a famous, here's Wolf-Hirschhorn critical gene 1, and LETM1, which I'm not going to go into what the LET and I don't even remember what that means. These are important genes in the region. these genes in cancer, they're actually upregulated, so they're doing more. And of course, our patients are haploinsufficient, meaning they're missing a copy, so they have actually less function of these genes. So that is not a direct connection. So if overaction of these genes causes cancer, then you would actually expect that a Wolf-Hirschhorn patient would have less cancer. I went through the entire region and looked at every gene and pulled it up, tried to see if they had any cancer predisposition. There are no genes in that region that, when deactivated or downregulated, that we've seen in cancer to be deactivated or downregulated. So what they do is they do these weird studies where they take a tag and they look at how much protein is in a cancer cell versus a normal cell. So they say, how much LETM1 protein is in this cell? Is there more or less than normal? And if you look, or these other genes, is there more or less than normal? In cancer cells, we only saw ones where there were more, not less. So there are no genes from this region that have been that I could find that have ever been low in a cancer cell. So that's actually reassuring as far as cancer risk. I did find some that when I look at what the gene does, I could speculate that downregulating them might contribute to cancer, but nothing that was actually ever proven in the literature. So then these are the genes. And if you do Wolf-Hirschhorn, you don't recognize these genes because these are not genes that we get really worked up about as far as critical genes for Wolf-Hirschhorn. But they are in that region, the 4p16. Okay, so I didn't really find a good gene candidate for possible causing cancer. That being said, we can speculate on other pieces that might contribute to the risk. So we know that people with Wolf-Hirschhorn syndrome don't quite have normal immune function. And the most typical, actual immune system diagnosis that we have in patients, so if patients have gone and seen an immune specialist, is common variable immune deficiency, which is really kind of means your immune system's not quite as good as we would wish it would be, but it's certainly not something severe. In other conditions where we see immune deficiency, we do see an increased risk for cancer. So, and that's sort of non-specific for immune disorders. So if you're looking at patients with, SCID or the 22q deletion velocardiofacial and some of these things, there's not high, but there is a slightly increased risk for cancer. And we know for sure that if you suppress somebody's immune system, you increase the risk for malignancy. Everyone who's on immune suppression, if you have rheumatoid arthritis or psoriasis, or if you've had a transplant and you're immune suppressed, we know that increases your risk for various types of cancers. The other piece is that many families have reported to me that they feel like their children have premature aging. And there are other premature aging syndromes that are associated with an increased risk of cancer. Some of the progeria-like disorders do have an increased risk for early. I don't know if it's an increased risk for cancer or an early onset cancer might actually be more accurate because, of course, the risk of cancer increases as you get older, no matter what your chromosomes look like. But if you're getting older faster, you can. And in early aging disorders, we see cancers, just that you would see in an older person, except they come on earlier. So it kind of just associates with the premature aging. So that would be another thing that would sort of contribute to our concern. So the question is, do we have an increased cancer risk? I kind of talked through this already, but there are a few issues that make us think possibly. So number one is, for the possibly, is that either loss of heterozygosity or just loss of the region of 4p is frequently reported when they look at cancers, like when they just look at the cancer cells. And then there's the immune dysregulation, the abnormal immune system. And then the evidence of premature aging. And then the question is, does the cancer rate in our population make us concerned? And then for no, so the cancers, so when I was going through the cancers, if you look at cancers where you see deletions in the short arm of 4p in the cancer, they're not the same cancers that we see in our population. Because it was bladder cancer and breast cancer. We don't have any bladder cancer. The funny inflammatory bladder thing isn't really a cancer. So we don't have any reports of bladder cancer or breast cancer in our population. So that doesn't match up very well. Also, there is no clear molecular mechanism. because the genes in the region that are associated with cancer, when you look at cancer cells, there's more of them, not less of them. So that doesn't really make sense from that perspective. And then again, the question is, how much cancer do we really have in our population? Unfortunately, we're actually working on getting a systematic study put together. But when I've talked to cancer experts, we don't have enough cancer to be super concerned, but it does raise a question. So this requires, unfortunately, more study, and we don't have an answer. But this is one of the things that's actively being worked on by several different researchers. And this is great because this is an area where we showed a response to what our parents actually need and want, and a response to what patients are concerned about, instead of just like me being like, what do I want to study about Wolf-Hirschhorn? But we still need more work because we don't have an answer yet. Okay, a little more information. So on LATM1, this is a different area of research that's sort of actively ongoing. This information comes from my partner, Dr. Lisa Scamenti, who currently works with me at the University of Minnesota, but she is leaving and going to the Mayo Clinic, which most people have heard of, the Mayo Clinic. They recruited her away with a great package, which we're happy for her. And she's not going to be very far away, so I can still find out what she's doing. So LATM1 is a famous gene, because this has always been considered a gene that's in the critical region. It's always considered to be a gene that contributes to what's happening to patients. It is nearly always deleted. Not always, but nearly always. The majority of our patients, this gene is affected in the deletion. We have lots and lots and lots of patients who've deleted this. Previously in the literature, there have been no patients who have an isolated mutation just of LATM1. So there's a lot of people who've mutated it in mice and things like that. So we have some mice who have mutations, but we've never seen what is, if you just ding just LATM1 in a human, what does that look like? Well, so a little bit about LATM1, which we don't really understand perfectly. It's probably a mitochondrial gene, and it likely contributes. There have been a lot of parents have reported that they feel like their kids might have a mitochondrial disorder or features of a mitochondrial disorder. This gene likely produces that part of Wolf-Hirschhorn syndrome, because this is an important mitochondrial gene. It controls ion flux in the mitochondria. So important ions across the mitochondrial membrane. It's very important for good mitochondrial function. If you ding this gene, your mitochondria do not work right. They look abnormal. And of course, if your mitochondria don't work right, your mitochondria make the energy for the cell. They produce, they're like the engine. They make the energy for the cell. And so if your mitochondria aren't working right, your cell will not work right. Lots of people will tell you they know what LATM1 actually does. If you look at the literature from mice and from cell culture and from other animal models, it's not totally clear what it does. Exactly does. Other than we know it moves ions around. Okay, but we found a human patient with this. So this patient came to see my partner, Lisa Scamenti, when he was about 5. And she said that he had been pretty normal until he was about 4 months. When she met him, he had a sort of a long, narrow head. So dolichocephaly is when the head is longer this way than it's this way. He had a high forehead, so the forehead was big this way. Prominent forehead. Epicanthic folds are just a little fold right over. I mean, you've probably seen people with a little fold right over the corner of their eyes, so you can't see where the tears come out. And he had kind of a weak face, so the corners of his mouth kind of dripped down because his face was weak. Normal size head. He's very weak. He can't hold up his head. And even though he's 5, he really just, all he can do from a motor perspective without assistance is roll. And he can't sit without help. And I did get to meet him, so I examined him myself as well. He actually had sort of high tone in his legs, so his ankles were really tight. That's what this doctor stuff up here means. He had normal growth, which I think is a key piece of information about LATM1. He was nonverbal, He would try to play, but he had a little trouble with his fingers, so he couldn't get like a clean grab on a toy, so he would kind of swoop at it instead of grabbing it. And he feeds himself, but he never got past eating purees, so blended up food. So he has to have squishy food. He can't like bite and chew something that's firm. And he does have seizures. They started in infancy. He did well with Keppra, which is, oh shoot, I have its real name somewhere else on the talk. Kepra's unfortunately a trade name. And then he had a brain MRI, which was essentially normal. So no brain abnormalities to explain the seizures. So he had a whole bunch of metabolic studies because someone suspected mitochondrial dysfunction, which was really legitimate. And these are things that we see. This is really kind of your liver's maybe not perfect result. That's what this means. And of course his liver. So it looks like his liver is a little bit not quite working right. And then orotic acid, it can be a sign of, again, abnormal liver function. So this kind of looks like he had a little bit of liver problems. And so they've done a bunch of workup, which I'm leaving some of it out. And eventually they did exome, which is where you look at the DNA sequence, the spelling of every single known gene in the genome. So you skip the parts that aren't genes, but you're looking at all the genes. So it's not so people say whole genome sequencing. I don't usually do that clinically because I don't know what to do with the stuff that we don't know what it does. So I tend to skip that. So anyway, so we found the other thing I forgot to mention, this child's parents were actually related. And so he had a mutation in both copies of his LATM1 that was damaging. So this is a patient who just has dysfunction of this gene. So I feel like this gave us a little bit of good information about what LATM1 might be doing in humans. And this is the first, I think Dr. Scimenti is working on actually getting this reported in literature. But so it's clear that LATM1 is really important for neurodevelopment. So it probably does contribute to the developmental problems that we see in Wolf-Hirschhorn. It's probably important for neuroelectrical stability. So it likely does, it's always been the candidate seizure gene for Wolf-Hirschhorn. And this is supportive of that because this guy has seizures. And Keppra is one of the medications that patients tell me a lot that work well in Wolf-Hirschhorn. So the fact that his seizures, he had kind of a typical seizure profile, and then the fact that Keppra worked pretty well matches up with the seizure phenotype that we see in our Wolf-Hirschhorn patients. His growth was normal. So that suggests to me that this is not the growth gene for Wolf-Hirschhorn. So at least that's a piece of information. And obviously we need to look at this a little bit more. And it'd be wonderful to find a few more. There've got to be other patients. He had a pretty nonspecific sort of seizures and developmental delay presentation, what we would call an epileptic encephalopathy. And so hopefully as we're doing more exomes, we'll find more patients who have LATM1 only mutation. We can give us a little bit more information about what that means. And probably some of the other genes in the region too. So, okay. So the next piece of research information I'm going to talk a little bit about is this collaboration that I've been participating in. And this was something that Amanda Lortz, as the executive director of the 4P- support group and the 4P- support group in general, really did, working with the University of Utah and also with Lineagen. And this is where if you remember my disclosure slide from the beginning of this whole talk, this is where Lineagen's financial support comes in. They supported the research. They also provided some lab support and people to help with the research too. So, so it's a collaboration between the 4P- support group, and this was really started up by parents in the 4P- support group saying, we want to do some additional research. We want more research. And then several academic medical geneticists and Lineagen responded to that. Primary site for this study is really University of Utah, which is where Dr. Carey is based. And then the second place, this is, so Dr. Battaglia is affiliated with the University of Utah, but his primary site is in Pisa. So this is where he works most of the time. But, he's kind of I'd say he's well, Dr. Carey's a big expert too, but Dr. Battaglia is probably our number one expert. And then a couple of people, one person from University of New Mexico, and then this is me. So it's hot off the press. So Karen Ho is the lead person on the research. She's a laboratory scientist who does a lot of cytogenetics, and it just got accepted for publication. So this is and I talked to Dr. Ho. She said it was okay for me to talk about this today. So this is hot off the press. You are the first people to hear about this. So we found a new seizure susceptibility region. So before this, and I talked about this a little bit because I was talking about LATM1. Up to this point, LATM1 has been our leading candidate gene for seizures. So, I was talking about how Wolf-Hirschhorn is a contiguous gene deletion syndrome. So there's not just one gene that gives you Wolf-Hirschhorn. We tried and tried and tried. Dr. Marcella Zellino, particularly, she's also from Italy, did so much work trying to find one gene that explained everything in Wolf-Hirschhorn, but we haven't been able to do that. And it really probably comes down to a combination of several genes and likely different pieces of the disorder are due to changes in different genes. That being said, we were all kind of thinking LATM1 was the seizure gene. It's probably not the growth gene, but we thought it was probably the seizure gene. So partially because it's clearly a mitochondrial gene. Lots of mitochondrial genes contribute to seizures. It's an ion transport gene, and I can't even tell you how many ion transport genes have been implicated in seizures. Like a lot of the sort of seizure disorder genes I'm transporting ionized molecules across membranes, and that's what it does. And so just based on what LATM1 does in a cell, we thought this is a great seizure gene. And also, most of our patients have hit this gene in their deletion. They have taken out one copy. So, but Dr. Ho was able to find, with help from the rest of us, of course, a new seizure region. And this is how she found it. So 48 patients participated in our study. They were all recruited from the 4P- support group at one of the national meetings. 90% of these patients had seizures, which if you notice, if you look in the literature, they'll say 95% of patients have seizures. It's actually probably a little lower than that. Just like everything else, the literature really skews severe. So if you read about Wolf-Hirschhorn, they'll pretty much say it's worse than it actually is in my experience. So what she did was she carefully studied, with the help of Dr. South, the precise deletion breakpoints in the population, and found that seizure activity in our population was located to the terminal 751 kilobase pairs, that's what KBP are, of chromosome 4P. So it's on the tip. So the telomere just keeps being really important. This region actually correlated better with seizures in our population in the 4P- support group in the States than haploinsufficiency for LATM1 did. And here's the stats people, just to prove that they did stats. I'm not very good at stats, so I'm not going to comment on the stats, except that is quite nicely significant. Heidi's nodding, that's a good sign. So the nice thing about the study is she didn't just look at their chromosome test results and whether or not they had seizures, which is something we typically do. She actually managed to get a little bit of data on what medications people were using, which is what I want to know, because I care about whether or not you have seizures, but I also want to know what I should do about it. This was lended support to what Dr. Battaglia has been sending for years, because Dr. Battaglia is actually a neurologist and he's a seizure expert. And so he's always had this list of what do you try first. So in our study, levetiracetam, which is Keppra, which caveat here, Keppra is the single most popular to be prescribed seizure medication in the States. So neurologists in the U.S. love Keppra or levetiracetam a lot and use it all the time. So there's a little bit of, that's a little bit of skewing because that's the one that they're going to use first. So you have to remember that. That being said, it was the most effective in our population. Dr. Battaglia is a huge fan of valproic acid, and that's what he usually recommends. Some of that, I think, has to do with how insurance coverage works in Italy and what you can prescribe more easily in Italy, because levetiracetam is more expensive. And I don't know about how formularies and stuff work in Italy, but, and you all know that medication prescribing and healthcare in the States is kind of messed up too. So, anyway, so this was also, valproic acid was also really effective, which is what Dr. Battaglia always says in his population as well. And the other thing you should know is valproate is not as popular in the States because it's not new and cool, and we love new and cool. And valproate's been around. The doctors here know that the valproate's been around for a long time, and so even with the bias in the data, this really supports what Dr. Battaglia has always said about seizures. Phenobarbital was the one that parents really didn't like. They felt like it had a lot of side effects and it didn't work very well, which tends to be my experience with phenobarb too, because it's very sedating. I mean, it just kind of, yeah, your kid's not seizing, but that's because they're not awake, which isn't exactly what you want. So, and then people also didn't have a good experience with topiramate, which is also called Topamax in the States. I don't know what the brand names are here in Norway. And didn't have as much data about why people didn't like that one. I'm guessing it just didn't work as well. So, and that one does have a lot of side effects too, of course. All seizure meds have side effects, so it's just how bad are they and how are they interacting with your kid and your life. So, okay. So then everybody dug through the literature and compared what we know in the literature about the regions and then the reports of seizures. And so after looking through literature and picking out cases where they had interstitial, smaller deletions that, because if you just use the big deletions, of course, it doesn't help you because they all have knocked out a lot of the same genes. They were able to further tighten the region to a 197 kilobase pair region, which is actually, in the grand scheme of chromosome deletion disorders, this is a very small region. And those of us who aren't cytogeneticists probably don't need to know the exact kilobase pairs, just know this is actually a relatively tight region for this kind of thing. And it's pretty close to the terminal end of 4P. And there were only 3 genes in the region. Unfortunately, we know nothing really about anything but this one. So that makes it a little bit less exciting. So we have 3 genes here in our candidate seizure region. And here's a picture. So, I've showed you so many pictures now of the end of chromosome 4. So this is chromosome 4 again. Here's the centromere. So this is the P arm, right? So this is really close to the tip. This is really, really close to the tip. So, and here's the gene. So here's PIGG here, and here's the other 2. And as you can see, there's actually a lot of overlap here. So this isn't probably even really quite 2 separate genes, maybe. And certainly, if you get one, you're probably going to get the other. So it's going to be really hard to tease these apart as far as their importance anyway. And one's a pseudogene anyway. So, okay. So after talking about it at length and digging in, Dr. Ho is really positing PIGG might be a good seizure candidate gene. It's a structural gene, really, in a lot of ways. So it helps to hook other important proteins to the plasma membrane. So you get your cells wrapped up in a plasma membrane, and it's just a hook could hang you, so you hang other important things off of it. And this anchoring system is ridiculously complicated. It's got like gabillions of. When I was trying to study this, and I didn't include a diagram of it because it just looks horrible. I didn't think it would actually help. So the potential mechanism for seizure susceptibility for problems with this protein. So in fish, of course, fish are not humans, not even close. although they are tasty. In fish, this anchoring is important for one of the things this anchors is what's called voltage-gated sodium channels. So voltage-gated sodium channels are little channels that pop open depending on the voltage, so the electricity on either side of the cell, and so they respond to the electrical signals around the cell and open and shut. And they let sodium in and out, which is really, 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 really important for cellular function and cellular signaling. And the other thing is the voltage-gated sodium channels, problems with voltage-gated sodium channels have been found in other serious and important seizure disorders. And one of them, that's where Dravet is an important seizure disorder, and that's why I threw that in there. That's known to be associated with voltage-gated sodium channels. So it doesn't, certainly looking at what the gene doesn't rule out contributing to seizures anyway. So I don't know that we've proved that this is I think, of course, there's not ever going to be, I think what we really understand from looking at Wolf-Hirschhorns is we're never going to find the gene for every single piece, but it does look like this is a good candidate for contributing to the seizure phenotype in Wolf-Hirschhorn. And Dr. Ho is still working on this, so there's going to be more data, hopefully. This gene is technically a congenital disorder of glycosylation gene. So it would potentially cause also, if you knocked out both copies, one of the congenital disorders of glycosylation, although there's not really, I couldn't really find a good human phenotype for that gene and when you've knocked out both copies. So that being said, it certainly is possible this is one of the candidate genes, although I don't know that we've really ruled out the other two. I mean, I'm pretty convinced that this region is important. I'm less convinced by this gene, although it's certainly a possibility. Okay, and unfortunately, at this point, we don't have any way of targeting this gene or improving its function, which would be one of the reasons we're looking for these things, is because if you really understand the gene, sometimes you can attack it. And we've been able to do that in other disorders like cystic fibrosis. They have medications that attack specific gene problems. And in some of our lysosomal diseases, we've been able to make the protein that the gene is supposed to make a working one and infuse it. And so that's where we're really going with this. Is this a therapeutic target? Can we find a drug that modifies it, or can we some other way attack the function? And so that's where we're really going. We're not just, oh, it's interesting to find out what every gene might do. But at this point, we unfortunately don't have a good targeting pathway, although it might help us make some decisions about seizure medications if this is a piece of it, if the voltage-gated sodium channels are really important. Okay, the other thing that Dr. Ho is working on is additional genotype-phenotype correlation work. I've been beating genotype-phenotype correlation to death in my talk, but it remains a big struggle in Wolf-Hirschhorn because, again, what's the number one thing that I want to give you as a geneticist when you come to me and I diagnose your child or your patient or your student with this disorder is, what does it mean for them? Where are we going? What can we do? And so this is the holy grail of studying Wolf-Hirschhorn is how can we use the testing to tell us what's going to happen. Tons of work by all sorts of really smart people. Dr. Zolino does other things besides Wolf-Hirschhorn, but this is definitely one of her big obsessions. And she makes at least a poster every year about trying to get better genotype-phenotype correlation in her population. Dr. Carey, of course, cares hugely about this. I work on this as much as I can, too. And then obviously Dr. Ho's group is working on this. As you know, because this is a center for rare diseases, 4P- disorders are rare, and it's hard to get enough people into a study to get good statistical power. And everyone here is nodding because statistical power, no other doctor will believe you unless you can achieve statistical power. And the way you do that is just by getting a lot of patients. And we don't have a lot of patients. Even in the United States, our population doesn't qualify as a lot. So, a nice big study for the literature is like, thousands and thousands of people, which you can only really do for things like heart disease and high blood pressure. But So it is hard to get enough people to do really good studies. And then the other piece of this is Dr. South and Dr. Ho have really looked at this. They've looked through the literature. They've looked at every single microarray study that Dr. South has ever run. And she's run a lot of them because she used to be the head cytogeneticist at R.U.L, which is a huge reference lab in the United States. Huge. It's probably right behind Mayo Laboratories. No two unrelated individuals have the exact same deletion. So this is really true. I've suspected this for a long time. But nobody with Wolf-Hirschhorn has the same genotype, except siblings. So that makes this extra hard, or maybe helps, I don't know. But, and then of course, as I was belaboring earlier, a lot of people have an additional copy number. They have an extra piece of something else in that hole where the 4P part should have been. And then of course, it's not always the same thing. I mean, the biggest number is that's a piece of 8, but it's not always the same piece of 8. And it's certainly not always 8. It could be lots of other things. And so that just makes it, and of course, the other thing, of course, in cytogenetics and genetics is that finding out what having an extra piece of something does is about 20 times harder than finding out what a missing piece does. And it's hard enough to figure out what a missing piece does, as you noticed from my blathering already. So this is really hard. But Dr. Ho is working on it. And this is her, and I am helping. I do the phenotyping part, not the genotyping part, which is I look at the patient and try to find out what the patient has going on to contribute. So here's a little picture. So these are some of the putative critical regions. So this is just showing you when people try to cone down the size of the deletion to the smallest possible deletion that could be thought to cause Wolf-Hirschhorn. This is just so you know what these other lines mean as it's sort of a legend for the figure. So these are the group. These little stars are people who didn't take out the terminal region. So because really in a lot of ways, most Wolf-Hirschhorn patients take out the tip all the way to the tip. So they've hit the telomere. And these people have preserved their telomere. That's what the star means. And then there's this one really odd one here, which is actually kind of far down. This person does not have Wolf-Hirschhorn by any definition. But, okay, so this is just looking at, and you see none of them match. Absolutely none of them match. And we had a nice range of different deletions, including some people who are non-terminal, to try to just do some genotype, phenotype. This is some preliminary data that Dr. Ho put together, just looking at, we had this little survey, and you could just kind of check off different problems that each kid was experiencing or different pieces of the disorder that each kid was experiencing. And then she just tried to correlate them. And this is just a typical scatter plot. So because the first question I always get is, how bad is it? You know, which of course is a hard question because what makes it bad? But anyway, that's the first question I always get is, how bad is it? And so this is a sort of an attempt to answer that very big picture. Like, because sort of the definition of how severe is your Wolf-Hirschhorn, well, the total number of problems you have would certainly contribute to that. So that's what she's trying to get at here. Although how bad each problem is, like if you have 2 seizures in your whole life, even though you have seizures, is that really very bad? No. Whereas if you have intractable seizures, that would be much worse. But we're not, that piece didn't go in, not how bad is this. Is seizures, yes, no. Heart defect, yes, no. Kidney problems, yes, no. That kind of stuff. So we do see a little bit of a trend of the more genes you've deleted, the more problems you have. It's sort of just a very big picture. And this is what we've suspected for a long time. We've always said that from a big picture perspective, the bigger your deletion, the worse your Wolf-Hirschhorn is, just in a very looking at it from, 20,000 feet. And so we do see that. And the other thing that you should know about this graph is the blue diamonds are people who just have a deletion. And this is with doing very good chromosome studies. And the red boxes are people who have an additional piece of something else as well, which of course, and these are not super tight correlations. Anyone who's ever looked at one of these scatter plots will say, that's a pretty bad scatter plot. So these lines are very general, but it does support that there is at least some sort of a correlation between deletion size and the overall number of problems that the patient has. And then there's been tons of work on individual deletions and individual genes and trying to find out what they do. And I was talking to Dr. Carey about this, and he said, Wolf-Hirschhorn is the single best diagnosis for the description of what we would call a contiguous gene deletion syndrome. So Wolf-Hirschhorn is caused by having multiple genes involved. So it's not just one gene. You cannot pick out just one gene. So there's many genes, and it looks like many genes contribute to many of the phenotypic pieces. So I've got arrows to genes that have been suspected to be involved in seizures. So here's PIGG, which is the one that, and of course there's the other ones that are right next to it here, the ZNF and the ABC1A. So I wouldn't rule them out either as being participating in seizures. So we got this one here, and then here's LATM1. And see, this is a very small region here on the tip. Again, I forgot to mention, here's chromosome 4 again. Here's the centromere, so this is the PR. Here's our 1.6.3 band, which is the one we get really worked up about. And so this is a pretty small region we're looking at. This is really in the sort of critical region for Wolf-Hirschhorn. And here's LATM1. And then other papers have looked at CTBP1 and CPLX1 here. And then Dr. Carey particularly, and I have worked really hard on looking at the facial phenotype because that's one of the key diagnostic criteria. And it looks like this one here and these two are, so here's Wolf-Hirschhorn, that one's Wolf-Hirschhorn syndrome critical 1. That's why that got that name. Are likely contributing to the facial features that we usually see. And then these have also been implicated in poor growth as well. And probably because I think the facial features, your eyes tend to stay the same size all the time. Kind of, babies' eyes are almost the same size as adults' eyes. Your eyes don't grow a lot. There's a very standard size for eyeballs. And the size of your orbit, so the bone that goes around your eyes, is very dependent on your eyes size. So people who for some reason have a very small eye will actually often have a smaller orbit. And one of the things we do with kids who've had to have an eye removed for whatever reason is one of the reasons you put a false eye in there is to make the orbit grow. So it makes sense that the growth genes would impact the face, because really the face of Wolf-Hirschhorn is my eyes are big and the rest of my face is small. So it makes sense that the growth genes would impact the face, because they really do have small faces. And that was really proven by Dr. R.U.L in England when he did his high-resolution face imaging study. So they have petite faces with big eyes. Well, the eyes are probably normal size, actually, and then the face is small around it. And so actually, it makes them really cute, doesn't it? Really cute. I mean, not that cuteness is important, but it, big eyes is just, that's a lovely thing. Anyway, and so that's I think why the growth genes are the same as the face genes. Anyway, so meandering on about genotype-phenotype correlation, because I'm obsessed with this, because I think it's what helps us take care of our patients from a geneticist perspective, because what's my job? To use your testing to help you. Right, so we're trying. I don't know how much the testing is really helping, but we're sure trying. So what we know, it's likely that total deletion size is connected to overall severity in sort of the broadest sense of what severity means in a contiguous gene deletion syndrome. We suspect several regions in correlation with various parts of the disorder, like I was just talking about. I didn't talk about the kidney problems, because they're a lot farther down for P towards the centromere, and anyway, we don't know that, we don't have a really good grasp of that region, but we suspect that the kidney problems are actually closer to the centromere, but we don't have that region coned down very tight. Well, we don't know what exactly a lot of these genes do. I mean, I've been sort of belaboring that, but you can see that, like, I don't really know what most of these things really do to you. And so that makes it a lot harder. And then the other thing we don't know is how the presence of duplications affects the phenotype. Mostly because we just don't have enough patients with similar enough duplication pieces to get anywhere near enough data. And again, there's a desperate need for more research. And Dr. Ho is working on it.
Okay, I think we're going to take a break now.
Yep, that's it.
Yeah.
Oh, I'll talk about the registry next.
Yeah, because then you can take the registry.
Right, yeah, exactly.
Ok, vi tar en pause. Jeg korter den litt ned på 10 minutter, for hadde litt lengre pause i stad. Må bare sende inn spørsmål fra studioene. Det kan godt sende de på norsk, og så har vår eminente tekniker sagt at han skal prøve å oversette de til engelsk. Så det er bare å komme igjen. Det noen spørsmål i salen nå?
My mother was wondering about reproduction. Are there any known cases of people with Wolf-Hirschhorn having babies?
No, the short answer is no, that we don't have any known patients. I don't know. I mean, so the short answer is no one's had a baby that I know of. Mm-hmm. That I know of. Of course, we do not have all the data. The long answer is that when I've talked to, so the question is, we don't have any known fertility, but then of course the question is, could there be fertility, right? And most of my young adult women and teenage girls are having periods, and a lot of them are having regular periods, and they have relatively normal pubertal progression, which would suggest that there's certainly potential for fertility. And then we, like any other chromosome microdeletion disorder, we would assume the recurrence risk is 50% per pregnancy. It's always harder to know what's going on with boys, but the boys also go through puberty because, you know, normal pubertal progression, regular periods in women correlates with fertility pretty well. It's a lot harder to know about guys. They do seem to go through puberty normally as well, so there's probably potential for fertility. So, yeah, so I would suspect that especially in our young women and our young men who are on the higher functioning end, I would imagine that there's a possibility for having children, and we should probably be talking to them about birth control and keeping an eye on that kind of stuff, which of course, as pediatricians, we always love talking about sexual activity in our patients. No. But yeah, this is probably something we should be thinking about is fertility management. And I'm really glad that we've made a lot of progress in birth control and making birth control easier for women. So there's the implant options and the IUDs and things that are less work for the person. And I think that's a really great progress for some of this if you want something a little bit more durable as far as birth control. Yeah, but I think the possibility for fertility is there. Yeah. And there probably is somebody, we just don't know because they didn't get diagnosed. You know what I mean? I bet you there is. Someday we'll find somebody.
Noen andre spørsmål? Ok, da tar vi 10 minutter pause.
Of course, this is true always at scientific meetings, that people always finish up talking about research by saying we need to do more studies because that's what we always say. Because it's always true, you've never achieved all of the knowledge that you need. And if somebody says they know everything about something in medicine, they are lying. Never trust somebody who says that. So we're always talking about how we need more research. And of course, the other thing is we're always going on and on and on about how we don't have enough numbers. And part of that, I mean, the biggest piece of that is this is a rare disease, and we're never going to get the kind of numbers that the people who study high blood pressure can get, because goodness gracious, we all have high blood pressure at some point. And so one way to try to get at the fact that we don't have enough data that the 4P minus support group has been really going after for years is the need for a registry. And the support group had been collecting data on their own kind of in a sort of ad hoc fashion for years and years and years and years. But when Amanda and the other board members of the 4P minus support group approached Dr. Carey and myself about trying to really formalize getting at some research, we realized that what we really needed was a patient registry. And so Amanda killed herself because a lot of registry services are very expensive, very, very, very expensive. And some of the big support groups have their own registries that they run themselves. But, I didn't think it would be that bad. Like, just, send out a survey and pop some stuff into a spreadsheet. Well, it's not that easy, obviously. So Amanda worked and worked and worked and worked, and she priced stuff, and she looked at the cost, and she looked at what they would do for you and how they would help you and all this kind of stuff. And so Amanda and the rest of the board picked out this CORDS registry, which actually comes out of South Dakota. It comes out of Sioux Falls, South Dakota, which is where my Larson ancestors emigrated to from just north of Oslo in the 1800s, and where my dad is from. And so that has nothing to do with why we picked this registry. It's just kind of fun. And so that's actually where this is being done. And one of the reasons for that is it was a good registry, and they also offer it for free because the Sanford name comes from this guy, and I forget, he's a multimillionaire in the States, and I forget what he actually made his money doing. But he donated an incredible amount of money. He's from South Dakota, so he wanted to contribute to medical research in South Dakota, which is actually kind of hard if you know anything about South Dakota. And so it's a very rural state in the U.S. It's right in the middle, kind of the north middle of the U.S. And there's no really big cities there, and it's pretty rural. And he's from there, and so he gave a huge chunk of money so that this registry could help rare diseases, and it's free. So they wanted to do a rare disease registry and just open it up and help support groups create their own registries, and they will do it essentially for free. So you don't have to pay any money for it because Mr. Sanford put up all the money. And so that was a big piece, because just like any other rare disease support group, we don't have enough people to have a lot of money. And so we couldn't put down several $1,000s a year to maintain a registry for it odd, and and of course the registry really needs to go forever forward. And so several $1,000s a year into the future forever is an incredible amount of money. And so this registry is supported by a foundation. So what is a patient registry? So patient registry is systematically collected set of information about patients with a particular condition. It can be anything. It could be blood pressure, it can be neurofibromatosis, or it could be Wolf-Hirschhorn. And a good registry, because of course there's lots of registries, and anything, even a spreadsheet compiled by a support group that just someone like me is just typing into their computer could be considered a registry. But so there's sort of a registry, and there's a good registry. So good registry, number one, is secure. That's the most important thing, because we don't just want you guys' data just splayed, all the patients' data just splayed all over the internets for anyone to look at. And so it needs to be secure. It needs to be confidential, so that only the person who should be looking at it can see it, even within the context of the registry itself. So if I'm sort of associated with a 4P- support group, but I don't have a legitimate research use for the data after I've gone through an ethics committee and talked to the 4P- support group, I can't just go in there and look at the data for fun. Like, I have to have a legitimate reason. It needs to be easy to use, because this is the problem with the sort of me just throwing stuff into a spreadsheet, is no one but me can probably get any data back out of the thing, because they don't know where I put anything, and I'm bad at spreadsheets, so it wouldn't be searchable. And so it should be easy to use. Of course, the other piece you need is it needs to be pretty comprehensive. Because somebody's going to want to look at seizures, but somebody else is going to want to look at growth, and somebody else is going to want to look at, reading skills, writing skills, speech, behavior, all these kinds of other things. And so it needs to be as big as possible, or possibly what we're really looking at maybe is flexible, so that you can, you don't just have one thing that you put in once and you can never add anything in. And it needs to be searchable. So once you put the data in, it doesn't help at all to put the data in if you can't get it back out, right? Because that turns out to be a waste of time. So Amanda and the rest of the 4P- board felt that this was the Sanford registry met all those criteria. Whoops, I went the wrong way. Okay, so why should we have a registry for 4P- conditions? And the more that I've worked on this, the more that I realize that this is what we need to answer some of our questions. So natural history data is sort of the first step in medical research when you're really trying to do meaningful research into a medical condition. So we don't even have all that great of natural history data on Wolf-Hirschhorn. What happens over time? Natural history is from before the patient is born until they pass away, what happens to them because of their condition. That's what natural history is. We don't even really have that. Like, those are the big questions I get, a lot of the big questions I get asked that I can't even answer, just natural history. So a registry allows collection of natural history in real time from real patients in a prospective fashion, i.e., I'm not like just pulling charts on a bunch of patients. Retrospective is when I say, I have a question about Wolf-Hirschhorn. I'm going to pull the 2 charts I have, because I actually only have 2 patients that I follow directly at my center, and look at them backwards. This is prospective, so it's going forward, which is huge in research. And everybody here who does research knows that that's a big deal. And then it can be queried by researchers. So these are I just threw up some questions that a researcher might ask of the database. You know, how many patients are adults? How many adults do we have? How many people have heart disease? Which seizure medications have been tried? We're also going to hope to have both what medicines have been tried and which ones were effective and what side effects do we see. That's one of the things we're trying to get in there specifically. The other big piece of a good registry is preventing loss of the data. So right now, most rare disease data sets are here. I'm not talking about myself as an important expert, but so a lot of the data about Wolf-Hirschhorn syndrome is in Dr. Battaglia's head, right? I mean, seriously, it really is. It's like, you know, I say, well, what do I do? I call up Dr. Battaglia. So what have you seen? You know, and so is this really in his head? And the other person who has a lot of it in their head is Amanda Lortz, the executive director of the 4P- support group, because she kind of talks to everybody in the support group. And so she's like, so I say, Amanda, how many patients have had a kidney transplant? She's like, well, you know, 2 or 3, or I can't remember, you know. And so, and it, you know, she knows who it was too. But that's just in her head. And if something happens to Amanda, boom, it's gone. You know, and so, not that I want to think she's a lovely, lovely person. So that'd be horrible on many levels. But so right now, these data sets in rare disease, and this is true really for a lot of the rare diseases. Like, I mean, you guys were talking about some of the other experts you've had come. A lot of that data on rare disease is really just in some person's head or a couple people's heads, and it's not written down anywhere. And then the other problem is, this actually happened to me, data sets maintained by researchers can be destroyed when they change jobs or when they lose funding. So, or when they retire. So the ethics boards of many major institutions, particularly in the States, claim ownership of your research. So if you leave that site, you have to destroy your research data. You can't take your data with you. And I actually tried to take some of my 4P- data with me by accident. I just had it when I moved after I finished my fellowship at Utah and went to Minnesota. And, you know, I had to go back and destroy it all because, you know, it was just on my computer and stuff. I didn't mean to take it. But so you have to get rid of it when you change jobs because it belongs. And, of course, there was no one at the university maintaining it, so I had to just destroy it, which is terrible. You know, and this really happens all the time in the States, and I don't know how the regulations are here, but if you change jobs in the States, or if you lose your funding, because sometimes maintaining your database is done by your research assistant. If you lose your money for your research assistant, that can be gone too. So having the researchers own and control the data isn't actually all that helpful. And then the other piece is facilitating secure and confidential interactions between patients and researchers. The other piece is if this is a support group and it's their registry, the data really stays belonging to the patients. So it's not my data, it's the patient's data. It's 4P- support group's data. So it's really theirs and not mine. And I think that's actually really important, both ethical and practical piece. If the support group has the data, then that stays with the support group, and that's not just one person who something can happen to, or they can lose their funding, or they can change their job, or they can move, or just lose interest in the topic, and then it's gone. And then this also allows the data to be in one place so different researchers can use it. So there's a group in Spain that's doing research, there's a group in Italy that's doing research, I like to do research, the Utah group does tons of research, and we can all look at the data and share it in a confidential and secure fashion. So that's another huge piece. So it's not just me hoarding my own data and you guys can never see it, you know, or only if you ask really nice or whatever. No, it's out there for So if people have appropriate ethics board approval and they're a legitimate researcher and the patients have consented for that data to be looked at, they can do it instead of one person kind of hoarding all the data. This is just a screenshot of the page, and here's the website here. So I personally haven't tried to enroll because I wouldn't have anything to put in there, but a bunch of our patients enrolled at our most recent 4P- support group meeting, and they said it was relatively straightforward. So we would really encourage patients, if they're interested in participating in research, this is a great way to contribute to worldwide research on 4P disorders. And active projects, I think, include, oh, here we go. I was like, I do have a slide about this. So active areas, we have an ongoing, somebody is looking at seizures, probably, it's Dr. Battaglia primarily, and then Dr. Ho. And then Amanda and I are actively working on trying to extract cancer data. And then oh my goodness, I've been working on this for, what is it now? It's gotta be 5 years. I'm obsessed with growth and Wolf-Hirschhorn, and I've been working really hard on growth charts, and we are updating and extending the existing growth charts. And the other piece we really want to look at is the things that we do to try to improve growth. Like I was talking about growth hormone, we have no idea how well it works because people have tried it, but we don't have any follow-up data on that. Like, did they grow? How much did they grow? Was it a really big pain to give the shots? And so one of the things we really need to look at, besides just how do kids grow with Wolf-Hirschhorn, which is what the growth charts do, is looking at what we're doing for it and whether it's making a difference. So, so a little bit more on the registry. Registry is only as effective as the patients that are enrolled in it. So if only 2 people sign up for the registry, then we'll only know about those 2 patients. And I really do think that at this point, after I've been beating myself up about trying to answer some of these questions for patients, I think this is the best way to get at some of the patients some of the questions that we're really asking about Wolf-Hirschhorn. Okay. That was kind of a plug. That's probably my biggest plug I have on this whole talk. Okay. And then any questions about researchy stuff before I go on to my next little topic here?
Did you say how many were enrolled in that?
I actually don't know right now. I would have to check. I think we enrolled over 50 people at the meeting, but I don't know where it's because people have been progressively enrolling, so I'm not sure where we're exactly at right now.
And
that's a really good question.
Enroll people from all over the world?
Yes,
probably.
Anyone.
Yes. Even the Norwegian.
They do not have it translated into Norwegian right now. I think there's English, obviously, because it comes out of the U.S. English, Spanish, Italian, I think French, but we do not have Norwegian yet. So yes, but we're working on getting more languages for the website.
And if I was a researcher interested in studying Wolf-Hirschhorn, I could apply to a board, and you will look at my application?
So you have to have IRB approval. So you get IRB approval, and then you contact Sanford, and you say, our ethics board has approved my research. This is what I want to look at. Yeah. So it's supposed to be pretty straightforward from the researcher end. I haven't actually queried the database yet myself. So, but yes, you should be able, you as a physician who looks at this, should be able to query this database. It's supposed to be quite straightforward. And I think that Sanford has an ethics approval process if you don't have your own ethics board that you can get approval from, because depending on where you work, some places don't have their own ethics board. So I believe Sanford also has an approval ethics review process, which is supposed to be straightforward. I haven't tried it, where they can do that for you too. So, and this is really open to any legitimate research. Yeah. So if you want to use it, yes. Should be. Okay. Other questions about research?